Welcome, everybody. My name is Matthew Stibb. I'm a cardiothoracic radiologist at Mayo Clinic in Arizona. And as Sandeep mentioned, I'm going to be talking about indications and planning CT for TAVR, more as an introduction for the rest of the talks. I have no disclosures. Our objectives today, we're going to analyze clinical indications for TAVR and compare those against surgical aortic valve replacement approaches, evaluate the role of CT angiography in pre-TAVR anatomic planning, and we'll talk about protocols, high-level protocol for TAVR planning. So let's start by going back nearly 40 years ago when the first percutaneous valvuloplasty was performed. So you can see that radiology has advanced significantly since then, as these were the best fluoroscopic images published in the Lancet in 1986, showing a balloon and catheter across the aortic valve and as deflated and then inflated here, propping open the aortic valve. This was before TAVR was around. Initially, there was some success, short-term success in terms of improving transvalvular systolic gradients, but long-term outcomes were quite poor as restenosis occurred pretty frequently. It wasn't until 20 years later or so when the first percutaneous TAVR was performed on a patient in France in 2002. This is an image of that TAVR on a balloon. And this was basically a last resort case of a 57-year-old man with severe calcified aortic stenosis. He had multiple comorbidities, was not a surgical candidate, and was about to die. And the cardiologists and team in France decided to try this valve, and it was technically successful. And one would think that this would have taken off quite quickly, but there was a lot of pushback from cardiovascular surgeons, as there was a strong belief back then that there was a need to resect the calcified tissues of the aortic valves rather than just push them aside, which happens in a transcatheter valve replacement. So it wasn't until 2011 when the FDA finally approved the first Edwards Sapien transcatheter aortic valve. Images here on the left of that valve. And here's the landmark New England Journal of Medicine paper published in June 2011, demonstrating non-inferiority of the TAVR to surgical aortic valve or SAVR replacement in high-risk surgical patients. And this was shown to be non-inferiority at 1-year survival. Interestingly, Europe approved this same valve 4 years prior in 2007. And ever since then, ever since 2011, when FDA approved the first TAVR valve, you can see this graph of TAVR volume to time on the x-axis from 2011 to 2019. And there's been a very steady increase in volume, 13,000 to 72,000 in 2019. The blue portions of the bars represent patients that are deemed high surgical risk, which make up the bulk of the patients that have received TAVR, but you can see also the orange bars have increased as well, and those are intermediate surgical risk patients. This is an interesting chart showing the progressive increase in volume of TAVR. So the black line is TAVR and the y-axis is volume. So TAVR volumes have increased, as we just saw. But when you compare those volumes to surgical aortic valve replacement, this blue line, in around 2015, 2016, TAVR exceeded isolated surgical aortic valve replacements for the first time ever. And this was when intermediate surgical risk patients were approved for TAVR replacement. This orange line on top is surgical aortic valve replacement plus an additional surgical procedure, such as a Bentall or CABG combination procedure. And this made up historically the bulk of all aortic valve replacements. But between 2018 and 2019, TAVR exceeded this as well when low-risk surgical patients were approved for TAVR. So you can see there's just been a steady, slow march increase in volume, which we're seeing in clinical practice as well. This is just another look at how indications keep expanding for TAVR. Initially, our first patient that we saw back in 2002 was inoperable and very high risk. Then intermediate risk patients were approved, and low risk patients were approved in 2019. And the question remains, in the future, will more groups of patients be added to this list of TAVR approval? And talking about this surgical risk, I just want to back up a second, as many of us might not be familiar with the STS surgical risk score. So STS stands for Society of Thoracic Surgeons, and the STS PROM score is the predicted risk of mortality within 30 days of a surgical procedure. And basically, you plug in clinical variables, demographic variables into this big calculator, and it spits out a percentage of mortality risk within those 30 days after surgery. And patients can be lumped into low risk, intermediate, high, and prohibitive risk. And so when I talk about groups of patients becoming ever increasingly becoming approved, we started with high risk patients, prohibitive risk patients, dropping down intermediate risk, and then finally these low risk surgical patients. All right, so kind of backing up a little bit more, what is TAVR actually fixing? So TAVR fixes essentially aortic stenosis, and calcific aortic stenosis is by far the most prevalent form of aortic stenosis. In fact, it's the third most common cause of cardiovascular disease in the developed world, behind coronary artery disease and hypertension. So, almost 2% of people over age of 65 have aortic stenosis, calcific aortic stenosis. Some risk factors include bicuspid aortic valve, and those patients tend to get calcification at a much earlier age. Age itself is a huge risk factor. So the older you are, the more risk you have of developing calcific aortic stenosis. And metabolic syndrome also is implicated kind of in a similar pathophysiologic manner as coronary artery disease occurs. Here are some photos of a normal aortic valve on the left, and on the right, a severely calcified aortic valve. You can see the chunks of calcification along the leaflets here. Pathologic images showing a normal trilaminar structure of the aortic valve versus a large chunk of calcium in that aortic valve. And this ultimately is the problem in calcific aortic stenosis. So what does aortic stenosis do hemodynamically? So severe calcified aortic stenosis leads to this impaired leaflet motion due to that excessive calcification, valvular area reduction, and then ultimately reduction in blood flow as it passes through that stenotic orifice. So Doppler echocardiography is the method of choice for diagnosing aortic stenosis, and as well as its follow-up. And you can see here, this is a short axis view, echocardiographic view of the aortic valve. The arrow is pointing to echogenic calcification, and the valve orifice is decreased. This is quite small. And this corresponds to the non-contrast CT showing similar calcification along the aortic valve leaflets. And then over here on the right, this is showing a continuous wave Doppler showing a quite elevated transvalvular velocity over 4 meters per second, which puts this person in the severe aortic stenosis category. So there's no effective pharmacotherapy that reduces this progression of stenosis and resulting adverse effects on the left ventricle. And those adverse effects on the left ventricle include diastolic and systolic dysfunction, left ventricular muscle hypertrophy, reduction in coronary flow reserve, and myocardial fibrosis. And what all this means is that ultimately the mortality rate for untreated severe aortic stenosis is quite high. It's 50% 50% of people have a mortality in the first 2 years if untreated after the onset of severe symptoms occurs. So this is showing survival, this red line, and then once severe symptoms begin, such as angina, syncope, or heart failure, if untreated at that point, the average mortality is 50% in 2 years. So you can think of that mortality rate in comparison to most cancers that we see, and this is basically a death sentence without treatment. There's a long latent asymptomatic period, as you can see here, as people progress from mild, moderate to severe stenosis. But the real kicker is when you start to get those severe symptoms. There are various stages of aortic stenosis. We're not going to cover these in great detail, but this green bracket is showing basically mild to moderate stenosis, aortic stenosis. These patients are typically monitored longitudinally with echocardiogram. And then the red bracket here shows severe aortic stenosis, either asymptomatic or symptomatic. You can have both forms. And in terms of what parameters we use to diagnose severe aortic stenosis by echocardiography, we use these three criteria. One is the aortic valve area, so how small the aortic valve becomes, and less than 1 centimeter squared is the threshold for severe. The mean transthoracic pressure gradient, so when you have that severe stenosis, you have a drop in pressure across that valve, and a greater than 40% millimeters of mercury drop is severe. And then also a peak aortic jet velocity of greater than 4 meters per second across that stenotic valve is considered severe. However, echocardiography is not perfect, and approximately 25% of patients have a discordant echo finding. So what that means is those three parameters might not all align to put a patient in severe category. Or the patient might have poor acoustic windows on echo, and findings are still inconclusive. So what has been shown is that we can do a non-contrast aortic valve calcium score similar to our coronary artery calcium scores, and get an Agatston unit calculation of how much calcification is within the valve. And if the threshold exceeds a given value, for men approximately 2,000 Agatston units, and for women approximately 1,000 to 1,300 Agatston units. If that threshold is exceeded, then the patient is bumped up to a severe aortic stenosis category. All right, so once a patient has ultimately been worked up and found to have severe aortic stenosis, and the life expectancy is expected greater than 1 year, then the next step is to proceed for an aortic valve replacement, and that is either going to be a TAVR or a SAVR, a surgical aortic valve replacement. And this decision is quite complicated and involves a multidisciplinary heart team to make a very nuanced decision depending on the patient's specific details. So this is a complex chart. We're not going to go through it in detail. I'm kind of going to give a high level of the decisions that are made. But really, age, surgical risk, and life expectancy are the most important features. Somebody that's high surgical risk, as we discussed earlier, should get a TAVR. People that are young age, less than 65, or life expectancy greater than 20 years should get a surgical aortic valve replacement. And this is primarily because TAVR hasn't been around for that long, a little over a decade now. And we don't know the longevity of these valves compared to a surgical aortic valve. People that are kind of in the intermediate age bracket, 65 to 80, you kind of have a equal option of TAVR or SAVR, depending on patient's wishes and other clinical factors. People that are old, over 80 years old, should go get a TAVR. Probably the most important part of this whole chart, though, for us as radiologists, if most of you guys on the talk right now are radiologists, it is the vital role that preoperative TAVR CT plays in selecting or excluding patients for TAVR over SAVR. And that's what we're going to talk about in the next part of the talk here. So the next few slides, I'm going to describe a high-level overview of what pre-procedural CT aims to accomplish, starting with the ACR appropriateness criteria published in 2023 as a general framework. So really, there are two broad categories of pre-intervention imaging. One focuses on the aortic annulus and the aortic root, and the other focuses on the supravalvular aorta, the chest, the aorta in the thorax, the abdomen and pelvis, as well as the iliofemoral vessels and vascular access. And this is really important for interventional navigation and planning, and the aortic root annulus is more important for choice of valve prosthesis, sizing of prosthesis, etc. So for the first variant, looking at the annulus aortic root, we'll focus our attention here on the circle here in red. This anatomy is evaluated with a cardiac CTA, preferably EKG-gated cardiac CTA. And what we're looking at is annulus size, in terms of area, circumference, dimensions, the overall aortic root features, including coronary ostial heights, which we'll talk about in a second, sinuses of Valsalva measurements, sinotubular junction, ascending aorta measurements, and then also just a general description of the calcifications of the aorta. And there are additional procedural planning items that can be addressed with the cardiac CT, including fluoroscopic angles that can be measured on CT that can help the interventionalist speed up their procedures in the angio suite if we already give them some of their angles beforehand. So in terms of the ACR appropriateness criteria, they recommend contrast enhanced CT heart, cardiac CT. And this is important. This is typically performed retrospectively gated. So this is a cine of the aortic valve, a bicuspid aortic valve with retrospective gating. So we can play a movie and see the function anatomy of the valve itself. We can look at the calcifications. And importantly, we want to make sure that we get a good image of the valve in systole, which I'll get to in a couple slides, but it's important to get that systolic image. Also of note, this cardiac CT is different from a normal coronary artery CTA, looking for coronary artery stenosis and CAD-RADS, and that we don't typically give beta blocker or nitroglycerin in order to slow the heart rate down and vasodilate the coronaries. And this is mostly due to the fact that nitroglycerin is contraindicated in patients with severe aortic stenosis because we don't want to decrease their preload and further worsening their potential symptoms as they cannot compensate for preload reduction. In terms of the aortic root, it's just an overview, a multiplanar reformat of the aortic root, highlighting the level of the annulus. And these measurements, subsequent speakers are going to go cover in more detail. I'm just going to highlight some of what we're looking at in terms of this cardiac CTA. But this black solid line is the annulus. We also can see the aortic valve with its calcifications, the coronary sinuses, and their relation to the ostia of the coronary arteries. All of these things are important for pre-intervention planning. Regarding the annulus, this is probably the most important part of the evaluation for TAVR valve choice in terms of the area, the size. So I spoke before about imaging in systole, and we do this because typically the annulus is larger in systole. You can see here versus diastole, and it's not a large difference, but sometimes it can be significant. And if you measure in diastole, incorrectly measure in diastole, you can result in TAVR undersizing, which can lead to paravalvular leak and subsequent repeat intervention. So, why CT? CT measurements have been shown to be better than echo measurements in a lot of different categories. One, CTA measurements are highly reproducible. There's been shown to be a decreased incidence of paravalvular leak versus echo, probably because we can more accurately assess those small changes in systole versus diastole. We can also look at the coronary ostial heights with respect to the annulus. So, if the coronary ostial heights are too low, the TAVR could potentially obstruct coronary arteries and cause subsequent symptoms. Also, it's been shown that LVOT, so left ventricular outflow tract calcifications, are associated with worse clinical function and outcomes, specifically increased annular rupture after TAVR placement, the need for a second valve, as well as residual moderate or severe aortic regurgitation. So, these things can all be seen on CT and aren't very well visualized on, or are not visualized at all on echo. Regarding coronary assessment for these TAVR workups, this is limited, as these patients usually have a high prevalence of significant calcified disease throughout their vessels, including their coronary vessels. So, they usually have high calcium scores, which significantly limits assessment of the lumen. Also, as I mentioned before, nitroglycerin is contraindicated, so we don't get that vasodilation. So for that reason, invasive coronary angiography is recommended and is usually performed prior to or as part of a TAVR workup. All right, so jumping into that second variant the ACR proposes is for pre-intervention imaging. We're looking at the supravalvular aorta in the thoracic cavity, the abdomen and pelvis, as well as vascular access. And this is accomplished with a CTA of the chest, abdomen, and pelvis, non-EKG gated. And really what we're looking for here, we're looking at vessel size, looking at vessel calcification, which is important, particularly dense circumferential and horseshoe calcifications, which are not great things for a large catheter coursing through a vessel. We measure minimal luminal diameters to make sure that there's enough space for these large catheters and delivery devices to get through, and also the vessel tortuosity. So again, these large catheters have trouble getting around a lot of tortuosity. And ultimately, CTA has been shown to reduce peripheral vascular complications, such as access site and bleeding complications and potential cerebral embolization. So you can imagine there's a lot of chunky calcification that can be scraped off with a large catheter. It can embolize to the brain. So this is just helpful to let the interventionalist know ahead of time. And also, if a patient like this on the left has a lot of calcified plaque in the iliofemoral vessels with significant luminal narrowing, you can determine alternative access sites for percutaneous access. So most commonly, the next step would be, if you can't go through the iliofemoral vessels, you can try the subclavian vessels. And so the CTA allows you to measure also the diameters of the subclavian vessels and assess for significant calcification there. Other access sites, which we're not going to cover in detail, would be the transapical approach and direct transaortic approach. But those are much less common. All right, so kind of to talk about some technical considerations, what we do want to have is a multi-detector CT with at least 64 detectors minimum. This is so that we get a spatial resolution that is in the order of 0.5 to 0.6 millimeters, so we can have a 3D data set and have the ability to post-process and create double oblique orthogonal planes, such as this example here, so we can get measurements in the true short axis plane of the vessel. Also, EKG gating is necessary for the cardiac CT portion, not for the CTA chest, abdomen, and pelvis portion. And also, it's almost required to give iodinated contrast for these pre-TAVR workups, really to assess for the lumen and get luminal measurements. But occasionally there are patients that can't get IV contrast for whatever reason, renal issues or severe allergies. And for those patients, non-contrast CT could be obtained just to assess for tortuosity of vessels and calcification level, but the luminal assessment will be significantly limited and measurements will be significantly limited. And I think I'm ending a couple minutes early to give some of the other speakers some more time, but thank you for your attention.